This week we've got Kevin and Payush and Sarah, I think, which are our pharmacists across the trust and are going to be doing, telling us what they do and hopefully giving us a bit of education.
So for those who don't know me, my name's Kevin. I'm on the ICU pharmacist based mainly at the Royal, and Piyush and Hussein and Sarah, we're all pharmacists working in ICU, and we'll all be involved in this presentation, this teaching presentation to you today. And it'll be mainly on optimizing antimicrobial therapy within critical care. So that's what we're focusing on. So if you go on to the next slide for us, please, Sarah. So the aims of the session will be to some of the challenges in critical care that you tend to see, some basic fundamentals that's important to know about before you go into any more complex things. Piyush will be presenting a couple of case studies on dosing within AKI and renal replacement therapy. We'll talk about some recent research that's ongoing with antimicrobial therapy, and Hussein's going to come in then and give us some more information on some of the more future advancements that are going to come our way sometime soon, and then some references for you all to help you your day-to-day jobs. Next slide, please, Sarah. So when it comes to prescribing challenges in critical illness, there's obviously a variety of those sort of things. And a lot of them are to do with multi-organ failure and altered pharmacokinetics that you see with our patient cohort, absorption variability via enteral routes, by other routes that we also have available to us, ever-increasing age, comorbidities, different medications that we're seeing being used within critical care. Obviously, during COVID, we started using MABs more than we have ever before, and the effect those have on our patients. Extremes of body weight, I think that's definitely within my career has become more of a problem. So we're seeing far more high body weight patients than we ever before. And unfortunately, the evidence doesn't really exist out there to help us optimize any medication dosing in this patient cohort, let alone antimicrobials. And then there's changes in the patient's clinical condition, so changes in PK, changes, and then not all drugs are able to be titrated towards pharmacodynamic goals, PD. Next slide, please, Sarah. So some of the basic stuff, and these are kind of things that we all tend to see, especially when we're coming over a weekend, that perhaps, you know, these are things that could be optimized relatively easily and could make a significant difference towards patient care. So the first thing is selecting the right dose. So the BNF can be a little bit unhelpful sometimes by giving you a very wide range of dosing for some of the antimicrobials. So drugs like tazocin and meropenem, they have relatively, you know, there's a 50% chance you'll get the dose right if you're not really sure. But you have drugs like Untitled where you can go from 300 milligram BD to 1.2 grams QDS. And in the sick patients with necrotizing fasciitis, you really won't be using the optimal dose, which is 1.2 grams QDS. And if you're only using the BNF and not using some of the other reference sources, it isn't always obvious to know which dose to prescribe. Same for amoxicillin, same for flucloxacillin. So it's important you get the dose right before you start thinking about how we can optimize other things. One of the other ones is right route and formulation. So it's important to know about bioavailability and not using enteral routes when the IV route is what you need to use, or switching sometimes when patients are on continuous enteral feed, you switch them onto an oral flucloxacillin dose that needs a feed break 4 times a day. So although that could be instigated, you then might reduce nutrition to the patient if a dietitian is involved to get the feeding plan changed. So we just need to make sure you're doing the switches at the right time when the right people are involved. Allergies. So I mean, it feels like half our patients are penicillin allergic sometimes, and clearly that isn't the case. So it's just important to sometimes ask the patient what their reaction is so we can use some penicillins rather than have to switch to alternate agents all the time. And then some interactions. So I don't know if any of you are aware of these interactions. So meropenem and valproate, is that one that anyone knows about? So it's quite a significant interaction where if you have a patient who's epileptic and he's on valproate chronically, starting meropenem can reduce the levels of valproate very quickly to 50%, 60%, 70%. It's a significant interaction. So, and then if that co-prescribing occurs, then you have to prescribe levetiracetam concurrently for at least 2 weeks after meropenem stopped to ensure they don't have seizures. So it's not without insult to the patient. It's one you need to be aware of, because we use a lot of meropenem in this trust, and we have a fair amount of people who are on valproate as well. Lesnid and SSRIs, I'm sure Ros would have mentioned that. We have microordrons, and the microbiologists have the Royal as well, so want to be aware of. Macrolide, particularly with statins and tacrolimus, and again fluconazole with tacrolimus as well. So both of those can increase tacrolimus levels quite significantly, especially if you have transplant patients. So those are sort of basics that are just important to be aware of. Sarah, the next slide. So see, these are some of the sort of basic PK principles. I'm not going to go into them in too much detail because it's an entire presentation on its own. I'm sure Hussein can testify. You could really get into some heavy detail here, but the volume of distribution, clearance, half-life, and then Cmax, C-minute area in the curve are all the sort of things you need to have a very good understanding about to be able to figure out how to optimize antimicrobial dosing. Want to click on to the next slide, please, Sarah? I'm not sure how well you can see this slide. Does it come up all right on there? So it's useful just to look at the grey boxes at the bottom, because that mentions about drug concentrations being reduced for hydrophilic agents, and then drug concentrations being increased as well for hydrophilic and lipophilic agents. So you can see with different types of organ failure, you get different end results, and different changes to the volume of distribution, in particular within critical illness, can get different end results. So hydrophilic agents, if the VD can increase in critical illness with increased capillary leak, increased fluid, particularly within in resus, we can circulate this sort of thing afterwards as well if people might find it useful. But just give you an idea of all the things that can change within critical illness to a patient, or the things we can change to the patient with extracorporeal circuits, which can affect how drugs are given. Go to the next slide, please, Sarah. So these are the pharmacodynamic principles to the antimicrobial prescribing, and it'll be clearer on the next graph when I come to show you that in a second. But you have time over MIC, which is duration of time the drug is over the MIC, Cmax over MIC, which is a ratio of Cmax to MIC, and area under the curve over MIC, and post-antibiotic effect. So if you flick onto the next slide, it should show it a bit more clear. So I think it's a graph you should be familiar with. I'm sure you've seen it before. And it gives you an idea of the different types of antimicrobials and how they work in different ways. So it's interesting with the time-dependent beta-lactams, or the ones that are ones that we tend to use a lot of, so things like meropenem and tazocin. And there's lots of studies going on at the moment about trying to increase that time over MIC to optimize that with continuous and intermittent infusions. With the theory being that if you prolong that time over MIC or optimize it as much as possible, you'll get better end results. But we'll come to see later that isn't quite the case yet. And this just summarizes that into the different antimicrobials. So you have type 1, which is concentration dependent, and they're your gentamicin, your amikacins, your aminoglycosides. You have type 2, which is time dependent killing, so time over MIC. So your carbapenems, your cephalosporins, your penicillins. And then you have the area of the curve over MIC. So vancomycin is mainly been the main one that we tend to use here with that. And then we'll talk about loading doses. So one of the key things here with loading dose, and I think it's a question we tend to get asked a lot, is about adjusting during AKI. So it's really important we don't need to adjust the dose in AKI. The loading dose is predominantly affected by the volume of distribution, not by renal function. So you give the loading dose, and vancomycin is a good example, but the vancomycin loading dose is the same irrespective of renal function. So you give that dose first based on their body weight. And the maintenance doses thereafter will be adjusted on AKI on renal dysfunction. But with vancomycin, it's really important that you give the loading dose without any adjustments requiring it for other antimicrobials as well. And these sort of agents can have their volume of distribution increased in critical illness as well. So if you give lots of fluid, the VD will be increased. So sometimes you have to give large loading doses. That sort of information isn't always written in textbooks or in reference sources, unfortunately. And it's one of those sort of things where you have to go back to basic principles to optimize those antimicrobials. Have you heard of augmented renal clearance before? That principle? It's essentially hyperclearance of a drug that's really cleared. it's quite hard. It's not something you can really measure or predict or do a test for and be able to say this patient's got augmented renal clearance and this patient hasn't got augmented renal clearance. You tend to see it in younger males with trauma, sepsis, burns, bronchiolitis, and it's when you have increased drug clearance of hydrophilactors, particularly beta-lactams. And in those patients, sometimes you actually have to use higher than licensed doses. So sometimes I've seen in other trusts, they've gone to sort of 6 times a day tazocin dosing, QDS meropenem dosing, and it's particularly within the initial sort of 24, 48, 72-hour window. Augmented renal clearance doesn't last. It's not a chronic thing a patient has in ITU. It normally sorts itself out within the first sort of 3-4 days of admission. And it's something that's relatively new, so we don't really know too much about it in terms of optimizing drug dosing. And it's something that we can easily measure as well, unfortunately. But it's something to just be aware of, particularly with patients who have trauma, sepsis and burns, whether for the initial period we may need to optimize that dosing to above a licensed dose. But you need to speak to a pharmacist really to find out the risks of giving a higher dose than they should be versus the potential benefits. And then there's TDM as well. So this is only as useful as when and how you take the level. So what I mean by that is, A, you've got to make sure the level is taken appropriately. So you take the trough when it's meant to be taken and the peak if it needs to be taken, and what the turnaround time is for the level to be sent back to you. So if you have patient testing on site, then the level should be back to you in the same day. So it means you can optimize dosing there and then. But when levels take 2, 3, 4, 5, 6, 7 days to come back, it's very tricky to use that level to optimize dosing for the patient there and then. I mean, the level might give you some information that what you did last week was not dangerous and the level wasn't toxic, but it makes it very hard to adjust the dose. And the same amount of information later about how that might be improving in the future, but we are still quite restricted to what we can do at the moment, unfortunately. Next slide, please, Sarah. And that just gives that's just a visual representation of loading dose versus maintenance dose only, and you can see you get to your therapeutic range much quicker when you give a loading dose than you do with just ignoring the loading dose and just giving a maintenance dose. It just takes longer over time to get to a steady state and get through to the therapeutic window. So drug dosing and AKI right now. So who here uses EGFR when they're on the ward rounds and representing patients? Do you think that's appropriate in critical care? Right. So EGFR is a so EGFR is an estimate of the glomerular filtration rate, because the GFR is not something we can actually measure easily on ICU, but it's predominantly based on CKD patients. The clue is in the equation that it tells you in iLab and ICE. It's an estimation from CKD FE equation, so it's not validated in AKI patients. And at the moment, the best option that we have is using the Cockcroft and Gault formula to get estimated creatinine clearance. I'm not saying that's a perfect equation to be having, but it's better than using the CKD estimate that we have at the moment, unfortunately. Ideally, we should be doing 4-hour urine collection of creatinine to get accurate creatinine clearance for patients, but I'm not sure of any ICU in the country that actually does that. And on a practical basis, I'm not sure. I don't know how that could easily be instigated into a daily routine within critical care. Not at the moment, anyway. It's also worth bearing in mind when we do work out creatinine clearance that different reference sources have different information. So SPCs, which are summary product characteristics, and our UHL guideline use creatinine clearance as their way of adjusting doses with AKI, whereas the BNF sometimes uses EGFR and the creatinine clearance and others. So it's important to make that distinction of when you've got a renal dysfunction number, that you're using the right dosing information to measure that against. Go on to the next slide, please, Sarah. So this is a bit more complex. I'm going to get a very brief discussion on this because it can get a bit heavy. So this is drug dosing and filtration, essentially. And there's 4 key things you just need to think about. First one is is the drug really cleared? Because if the drug isn't really cleared, then the importance of filtration will be reduced. The size of molecule and molecular weight. So the studies in the 80s and 90s tend to suggest that higher molecular weight drugs wouldn't be cleared by filtration. The problem we have now, to some degree, or the benefit, it depends which way you see it, is that modern filtration technique has improved significantly since the studies were done in the 90s, and the filters themselves are much more efficient and they clear larger molecules. So the size of the molecule and molecular weight of the drug, I think, is becoming less relevant for drug clearance than it used to be. But we don't have a vast array of studies that are based on modern filtration techniques. The data and the drug dosing data that exists is often quite difficult to extrapolate to how we do filtration nowadays. So sometimes the dosing based on that can be more cautious than it needs to be, and that's why TDM is really important. So it allows us to adjust for modern practice rather than using historical references. Protein binding is still important. So drugs that bind to albumin, for example, anything that's highly protein bound will increase in size significantly, and those will likely not be removed by the filter. And then volume of distribution again. So hydrophilic drugs have a low volume of distribution, and that allows them to be cleared by the aqueous filter fluids that we use. But you can talk about things like sieving coefficients as well, but that's quite an advanced topic, and I'm not sure it adds much more to drug dosing at the moment. This is just a pictorial example for ceftazidime because it's interesting. We look at reference sources about what it tells you about renal dosing. So the BNF doesn't tell you anything. So the BNF just says dose adjustments needed in renal impairment, and that's all you get. They're not particularly helpful. So the SPC, which is the top right, which is on the EMC website, see that gives you a breakdown from some information. It isn't always the most easy to read, and that's why there's some more nuanced resources that exist. So our own UHL guideline for ceftazidime, which I think is much easier to interpret, and the renal drug database, which is accessed by pharmacists, again has good summary, but it also gives you some fundamental information. So you see the protein binding there, the molecular weight, the percentage excreted in the urine, volume of distribution. So all that sort of fundamental information is in the renal drug database. So if you ever want that, trying to optimize a drug, if you ask the pharmacist, we'll be able to get that information for you, be able to go back to basics. Next slide, please, Sarah. So I'm just going to hand you over to Piyush now. We'll go through a couple of cases.
So, hello everyone, my name is Piyush. I'm one of the IT pharmacists based at Glenfield, as Kevin has said. So what I'm going to do is going to go through a couple of cases, just give some examples of what Kevin's already said, to point out some of the problems that we get on ITU and how to sort of adjust and navigate around prescribing a certain couple of antibiotics, sorry, antimicrobials, I should say, yeah. So first scenario we got is a female patient who's got essentially diabetic foot, gangrenous foot. We've given some basic patient parameters of height and weight and some medicines that the patient's normally on. So if you turn over to the next slide, please, Sarah. So in terms of Kevin's mentioned about weight, there's different formulations of, there are different formulas to calculate how you dose a patient based on the body weight that the patient's got. So we get, as Kevin mentioned earlier, we get a lot of patients who are heavier than normal. So in this occasion, we've got a patient who's over 120 kilograms. If you work out the ideal body weight, you get 73 kilograms. And the adjusted body weight, you get 82 kilograms. So it gives, in this scenario, we have the patient who's coming to ITU septic from the vascular surgery ward, we're going to call it. And then the decision in this occasion is to start on Vancomycin. So in the room I've got in front of me, what weight would you use to calculate the initial loading dose for the patient? Obviously, we won't need to acknowledge this for the loading dose. We don't need to worry about the EGFR or the creatinine clearance, but more for what sort of dose would you go for the loading dose? Would you use the ideal, the adjusted, or the actual? Adjusted? Actual, yeah. So as Kevin said, we need to get the loading dose right, because this is a hydrophilic drug, so we need to make sure the level, it gets the right concentration within the range earlier, rather than giving the wrong dose lower later on. Yeah. So okay. Next slide, please, Sarah. So renal function in this patient. So the EGFR 57, creatinine was about 179, and urea is about 12. So in terms of information, when you are trying to work out in terms of renal failure, acute or chronic renal failure, what sort of information do you need to sort of have in your head in order to work out what the GFR would be for the patient? So what sort of things would you say? Anyone in the room? So age, weight, sex, creatinine clearance, yeah, creatinine itself, yeah, muscle mass, yeah. So would you use EGFR or creatinine clearance to work out dose of the maintenance dose? Creatinine clearance, yeah. So these are the sort of factors you'll need to take into account. So not the one you get on the screen. So luckily here in this trust we have on the Antimicrobial website there is the EGFR, there is a creatinine clearance calculator on the screen. So put the details on, it will tell you what the creatinine clearance is. But you would use the I would use the adjusted body weight just to give it just to make sure, because to get the right sort of dose in for the patient. Sorry, for working out the dose itself. Yeah, for the creatinine clearance itself, you'd use the ideal body weight. Okay. So you all probably seen the Cockcroft-Gott equation before. Yeah. Next slide, please, Sarah. So, if just for example, if you did use the wrong weight, it shows you what the sort of creatinine clearance would come out. So you plugged in the wrong details. So if you use the actual body weight, you get a massive creatinine clearance of 64. And if you look at the equivalent dosing on the Vanc chart currently, you get a dose of 750 milligrams BD. When if you go to the ideal body weight, if you go to right to the baselines, you get a dose of 750 once a day. So you've got a big range of dose of this antibiotic, which could go wrong. Vancomycin is used widely, but it can have some toxic side effects as well. So making sure we are dosing it correctly for the patient's adjusted body weight in this occasion, yeah? Right, so next slide, please, Sarah. So on this occasion, we've decided that the patient needs to be on a 500 milligram BD dose, which is correct for that creatinine clearance for the patient, yeah? When would you take the level for the patient, assuming you count the loading dose as first dose, yeah? When would you start taking the next level for the patient to make sure that you're adjusting it?
Before the start of third dose?
Before the third start dose, yeah, that could be correct. Anything else? Yeah. So ideally, you would try and do it, depending on which, this is one of the nuances that we have within this trust, I could say. So the levels themselves, when we send them from the Royal, they can be done on site, whereas on this site, they have to be sent to the Royal, and there's always going to be another added delay that we wouldn't see at the Glenfield site or the general site, I should say, as well. So the third dose will be appropriate, or sometimes the fourth dose might be appropriate as well, depending on what time the dose has been taken. So if the third dose ends up being 9 o'clock in the evening, it will probably sit in the lab for a while and get transported the next morning. So there's probably no point no benefit in doing the level that at that time. It's probably better just to shift it to the 9 o'clock in the morning dose. So you can do it before the dose is given during the day, and that gives you time to react on it when the result comes back at, say, 12, 1 o'clock, or whatever it is, when it comes to the lab itself. Here's a common scenario we get. So we have a level that's been taken on day 4 at 3 or 3:30 in the morning. Creatinine is static, about 120 micromoles a litre, and if you're the prescriber reviewing the chart at 9 o'clock in the morning, the dose has been scheduled for 10. What would you think initially about that? What are the 4 options I've given you here? So you got either hold the dose, reduce the next dose, as the chart would suggest, to 750 milligrams once a day, which is the next step down, which is what's instructed on the Vancomycin chart. Ask for, or you could do a review before the 10 o'clock dose. Sorry, take a level before the 10 o'clock dose, give the dose, and then plan for the evening dose later on, or ask for a help, basically. What would you do?
B.
Hey?
B.
B? Any other options?
Or D.
D is obviously these often quite the famous answer that help. Yeah, D is an option. I would, if you're unsure, if you're really bamboozled or you can't see it, because sometimes there's lots of information. And if you're looking on the nerve center on the results screen, sometimes it's quite hard to interpret what time the nurse actually collected it, what time it's reported. Even I get muddled with that sometimes, but you have to take a step back, pause, and then reflect on the information you've got in front of you. So D is an option. I wouldn't say no to that. What I would say is probably option C is the better option here. It's quite clear. This is the dose should be at 10 o'clock. This is not a pre-dose level. This is 5.5 hours before the dose is supposed to be given. So your level is going to be elevated. It's not a pre-dose level. If you did take it at 10 o'clock, which or just before the 10 o'clock dose, if you change the slide, Sarah, please, I'll show you. If you took it at a more reasonable time, so this occasion, same dose, the nurse took it at 9:30 after you reviewed the patient's bloods in the morning, comes back at 20.5, which is slightly above the range, but not massively above the range. In this occasion, the decision to give 500 BD, 500 milligram dose, and take the level immediately before the dose is the correct dose. If you had reduced the dose down, the next day you would come back and then the level would be lower again, then you'd be chasing tails, you'd have to increase it again the next day. You get into a bit of a vicious cycle, which is not great, especially on IT when we wanting to, especially on, say, this whole patient who's got a deep sedative wound over there, necrotic foot. You want to aim for this MRSA infection, a high 15 to 20 milligram per liter dose, level for the vancomycin. Yeah. I think I've answered that question actually. Why, or would you alter the dose? So eventually you wouldn't. You would continue the 500 milligram BD dose. Yeah. So what other further actions would you take in this scenario as well for the future? Do you continue monitoring? Would you just leave it as it is, or review the frequency, or would you consider taking a level in the next 24 hours again?
Review those more frequently.
Review frequently, yes. So I would do it at least every 24 hours. The next practical day. So if you're taking a level that morning, unless the patient is renal function is deteriorating further, or showing more signs of sepsis or anything like that, then at least the next day. I know in the chart it says every third or fourth dose. But if you're on a once-a-day regimen, you could potentially on a Monday you might be taking the level to the next Friday, which might be totally inappropriate because anything in that 4-day block could change. So doing it daily more frequently is probably the better idea. That way you can adjust the dose and take into account whatever parameters has changed in the patient, which is on IT can change quite quickly. Next slide, please, Sarah. So next scenario. So I don't know if many of you saw many COVID patients in your previous rotations. So we've got a scenario here of a 57-year-old man who's got aspergillosis post-COVID recovery. So he's coming from a medical ward or wherever onto ITU. Basic drug history of hypertension, GORD, hyperlipidemia, reasonable height and weight. Reasonable height, 5'7" inches, which is about 1.7 meters. 100 kilogram patient weight. Again, if you do the adjusted body weight, it's about 79 kilograms. And then there's a request for Voriconazole to be prescribed for aspergillosis by the microbiologist, and assuming the code's been given, etc. And the loading dose on the IV dose is 6 milligram per kilogram for 2 doses, 12 hours apart. Then 4 milligrams per kilogram for the next dose. So if you turn over the slide, please, Sarah. Right, what dose would you prescribe? So I should probably made it a bit more clear. So the first dose is based on 100 milligram weight for the patient, or the second dose is the second line, which is the 480 onwards, is based on the 79 kilogram weight. Which dose would you go for? Which regimen would you go for up to 2? Anyone in the room at the Glenfield? I can see faces, but I can't hear you at the Royal. You got what? You got 50-50 chance if you want to guess. Let's just say that way. Nikhil, I can see that friendly face. Nikhil, go on, Nikhil. What would you go? Hey? Okay.
Yeah, it's second.
Second, yeah. So I've gone the adjusted loading dose, right? Or adjusted weight. So it'd be 480 which is roughly the right dose and for the first 2 doses, and then 320 BD thereafter. The only problem with this is that if you're doing milligram per kilogram doses, sometimes you'll end up with some really weird numbers. You might end up with something like 486, right? Which for a nurse, it's not great to sort of measure. The vials themselves come as 200 milligrams. So in order to make it more easier for the nurses, practically I probably would have made that to be 500 milligrams BD for the first 2 doses, and then 300 milligrams BD for the next doses. The nurses can't manipulate it to make that small milligram dose. So when you're prescribing, think about, is this dose practical as well? Is it a reasonable number as well? Yeah, according to the size of the vial. If in doubt, you can always ask from the pharmacist to see what it is, what is reasonably available and what is reasonably adjustable to. Yeah. So next bit of the scenario is the patient becomes acidotic and develops an AKI on day 3 of their ITU stay. Creatinine jumps up to about 300, urea about 45. Patient is started on CVH-DF, and they also have a CK level which comes back, because someone's checked it, of about 700. First question would be, would you consider reducing the dose down of the voriconazole while the patient's on this mode of dialysis on the unit?
I think so. No. The answer is when he was telling about filtration, about the molecular size.
The answer is you wouldn't. Incorrect. Yeah. Quite a lot of antibiotics you wouldn't need to reduce down the dose down to. So things like tazocin, meropenem, we wouldn't need to. The 2 common ones that we would use, we wouldn't need to reduce down the dose of the antibiotic while they're on dialysis. There are within the trust, we do have a dosing guide for antibiotics, or antimicrobials, I should say, while they're on patients on CVH dialysis, DF dialysis. So have a look at that. Don't just look at the BNF, which will go wrong, but look at the guidance within the trust. If you look at other references, it might be quoting other dialysis modalities which we don't use on this ITU currently. So don't go with the peritoneal dialysis modality or the intermittent hemodialysis modality. Use the guidance that we have. If in doubt, always speak to a pharmacist or look at the Antimicrobial website. Yeah. So the other question on this is, what may have contributed to this raised CK level in this patient? So if you just go back a couple of slides, please. I'm sorry. No, one more forward. Other way. There we go. Right. What on this presentation of this past history, what do you think might have caused this CK level to rise in this patient? Yeah, gut instinct is right. Yeah, atorvastatin. Yeah. So quite often people think of antifungals being quite, obviously the word benign and not causing many problems, but most of them will interact with other medications which patients come in on routinely. So atorvastatin is widely used within the UK and the world, I would say. So in this sort of situation, the atorvastatin effect was increased by the voriconazole. So you could potentially see an interaction in these sort of situations. There are a lot of interactions with things like fluconazole, voriconazole, amizone. So if you are prescribing these things, it's always vital that you just look in the BNF. Everyone has an online BNF now, or everyone has the app on their phone. A good source of use information I would find for checking what the interaction is. If still in doubt, then obviously the pharmacy team are available as well, and there are other information sources available as well. But don't assume ever that any antifungal you prescribe is going to be safe with all the rest of the medication that's prescribed in the chart. Look back and see what other things the patient is on. Yeah. Oh, sorry. Okay. Go to one more slide, please, Sarah. Thank you. Right. So on this occasion, so if you looked on the Antimicrobial website, it gives you a reference range for taking levels for voriconazole. So on this occasion, we have so on day 3 of the ITU stay at 11 o'clock, 400 milligram BD dose has been given. A level has been taken at 11 o'clock on the third day of the ITU stay. The dose was prescribed at 9 a.m. and 9 p.m. essentially. The level has come back as 10.3 milligrams a litre, and this was reported on day 5. So Kevin earlier did mention that sometimes the levels that we take don't always come back the same day. This is one of these levels that can come back a few days later, because sometimes we have to send to an external lab. It depends how fast the lab can turn that over. Some samples do get processed within our trust as well, but it's not always, doesn't always come back the day you request it, or in a 24-hour period. So you might get a result that comes back, I should say, a few days after the level was taken. So you need to look at what the result is. But what would you do in this scenario? So what's your thoughts on this in this situation? Do you think the level is high, low, correct?
Levels are high.
Levels are high, yeah?
Definitely.
Okay, so one of the doctors said level is high. Why do you think level is high in this occasion? So dose was...
Looking at the target levels, that's why. I'm not
Okay.
sure about the voriconazole levels.
So you're saying the level is high. So going back to the principles that Kevin was mentioned earlier, if you're taking levels of a drug, you need to make sure that you're taking, if it's a pre or a post dose, you're taking the right time frame recorded in the dose. What do you think is the time frame for this patient? So if it's a 9 o'clock dose, a 9 a.m. and 9 p.m. dose, and the level, if it's a pre-dose level, do you think 11 a.m. dose is correct for a pre-level? No, correct. Yeah. So 11 o'clock dose, 11 o'clock level for a 9 o'clock dose is not a pre-level dose. So in this occasion, the level will come high because it's still probably going through the body system. It's still, I think it's like an hour or so for it to infuse. So you'll probably got to the peak level, I would say, potentially, rather than a post level. It's not a pre-level, yeah, for the patient, potentially. So in this occasion, would you reduce the dose, or what would you do in this occasion? Do the level. You could redo the level. Obviously, it will take, on this occasion, this particular drug, it will take a few days for the levels to come back, but I wouldn't necessarily consider this as a valid choice to react on, basically, because you got false data, basically. Not data, but you got interpreted, I should say. So it should be done pre-dose. And if you did do it pre-dose, you probably would have got a range, a level within the range that would show that you any chance of becoming toxic. Yeah. So another scenario we got in this continuation of this patient story. So the patient on day 7, renal function improves, it becomes stable. The patient starts to absorb their feeds and everything. It's been stable for the last 40 hours before that. The AKI has resolved. Would you consider continuing IV voriconazole, or would you consider changing it to the oral therapy? Yeah.
Correlate clinically as well.
Say again?
Correlated clinically as well, how the patient is, like day 7 it is.
Day 7, so the patient now on day 7, yeah,
So
correct.
it's getting better.
It's got better, the AKI is resolved,
AKI is infection markers, for example.
Yeah, they need, yeah.
This fluconazole has been, sorry,
This
voriconazole
yeah.
has been-
So voriconazole, when used for aspergillus, it can be used, it needs to be used sometimes for weeks. So I think I've been told last time it's about 4 or maybe more weeks longer, depending on the level of how much there is in the body. So in this occasion, it might be less than 3 weeks, then the patient might be discharged from ITU onto a baseline ward. But would you consider using IV voriconazole for this patient, or would you consider changing to oral? Yeah, oral. Yeah. So quite often on here on the unit, we continue using IV therapy, when oral therapy is just as good. So on this occasion, voriconazole, if you give it orally, it's about 97% then bioavailable. If you swallow it, an IV injection is 100%. So there's not really much difference between the two. And obviously, giving it IV it's harder for the nurse to give, but the tablet formulation, the patient is stable. We might even be able to go home with it as well, potentially. So we're trying to reduce the risk of more IVs going to the patient, and it could give it more chance of other infections potentially going down the IV line, causing other sorts of sepsis, line for phlebitis and things like that as well. So if we can consider oral therapy, then we would do, and this is what we did do while during the last COVID surge that we had on this unit. We did try and convert as many patients as we could onto the oral therapy. Yeah? And again, if you wanted to make sure the patient is in right range, we could obviously repeat the level at a reasonable time, the previous level, to make sure that it is in range, to confirm that you are hitting the right target levels again. Yeah. So next slide, Sarah, I think. Sarah? Okay, so is this yourself? Yeah. I'm going to pass you on to Kevin, who's going to talk about the next business topic. Yeah. Thank you.
Thanks for that, Piyush. Okay. So this is just a quick summary then, just coming towards the end now, about just some recent research that's happened within optimizing antimicrobial therapy. So there's a few trials that have happened. I don't know if anyone's heard of any of these trials. Ring any bells? So they're mainly linked to continuous infusion of beta-lactam antibiotics. The theory being to optimize the time of MRC, like I mentioned earlier. So the theory, it does exist, and it's a strong theory, and you think that this would make a difference. But unfortunately, the evidence that's out there hasn't actually proved that to be the case, not yet anyway. So BLING-2 was a relatively large pilot study that was done across 25 ICUs in Australia, New Zealand, and Hong Kong. It was a relatively decent study design. Had appropriate randomization, concealment, and blinding, but it actually showed no benefit from continuous infusions versus intermittent bolus infusions. And it was underpowered to detect any mortality differences. They've nevertheless decided to do BLING-3, which is a much larger study, which is powered to detect mortality differences, and that's going to be over 7,000 patients across 70 ICUs worldwide. So it's a big study. It should give us some information, hopefully, towards the middle of next year, when the reports will be the results will be reported in 2023. BLISS again was another study that was similar about comparing continuous infusion of beta-lactam antibiotics. A relatively small study in comparison to the other two. Again, no mortality benefit at day 14 or day 30. And there's been a recent survey by one of the consultant pharmacists up north about antibiotic administration practices within ICU. And it's interesting, about 50% of those ICUs that were surveyed have gone to standard, continuous, and intermittent and prolonged infusion of antimicrobials as their standard care, on the premise that the evidence exists for mortality and for better endpoints in ICU, and that evidence just doesn't exist. And it's interesting when you dig into why those changes happen across ICUs. It's not led by clinicians or medics; it's been led by pharmacists themselves. So the pharmacists themselves have led themselves to believe the evidence exists based on theory, but when you look at the data that is out there from studies, it just doesn't, not on a large scale anyway. So it's interesting how practice evolves in ICU, perhaps before evidence necessarily exists, and that isn't always the case of the evidence. It can be the case that it's hard to prove things into critical care and get good studies that are well designed. And Leicester is one of those hospitals that don't use continuous infusion of beta-lactam, and I think during the COVID pandemic, Sarah made a really good point yesterday actually, that we didn't rely on infusion pumps as much, and we didn't actually run out of pumps, and many of the trusts did. And one of the reasons for that was because they used continuous and prolonged infusion of antimicrobials, but that led them to have a shortage of infusion pumps, which caused lots of other issues with the nursing staff. So it's interesting that there isn't always benefits for these. For continuous infusion, you'll type an IV line. There's no compatibility data for giving drugs with these prolonged infusions. So there may be some theoretical benefit, but there'll definitely be some challenges as well that you add into the unit for the nursing staff. I don't know if Hussein, if you're able to come in now and just have a quick chat.
Yes, it's unprepared.
Oh yeah, just give us a brief introduction.
Okay, my name's Hussein Munna. I'm honorary ICU pharmacist. I'm mainly involved in research in clinical pharmacology. So I didn't realise I was going to be finishing this talk.
Yeah,
But I think the reason that Kevin and Piyush thought it might be worthwhile if I had maybe say a few words is that a lot of my research has involved developing pharmacokinetic, pharmacodynamic models. And why is that relevant to the talk today? So precision medicine is all the rage. I'm sure you've all heard the term, even if you're not involved in research. And precision medicine talks about right patient, right drug, right time. Yeah, you probably heard that phrase as well. And I could add on something else at the end, which is right dose. Okay, and that would be then precision dosing. And I think precision dosing is really just perhaps one step beyond what the guys have been talking about today. So, you know, they talked a lot about how optimizing dosing according to some basic, you know, demographic characteristics, age, body weight, and some basic clinical characteristics, renal function, hepatic function, that sort of thing. Precision dosing can take it one step further, or quite a few steps further, because when you are using those characteristics to optimize the dose, what you're essentially doing is you're really trying to hone in on how that patient's going to handle that drug. You're trying to hone in on what that patient's pharmacokinetic characteristics might be, and you've added in a few explainers which might narrow it down. Because if you think about pharmacokinetics in the population, you know, any of those terms that Kevin started off with, clearance, volume distribution, half-life, it's a normal distribution, very much a Gaussian type of distribution. It's a little bit skewed, but it is. And what you're trying to do by adding in those various factors is try and hone in on where does this patient really lie in this normal distribution in terms of those PK parameters, clearance, volume, distribution, half-life. And that's fine, but you've still got quite a lot of variability in there, so you're never quite sure. And what precision dosing allows you to do is really target the individual. And how do you do that? You do that by really using models. Okay, and you've heard a lot about models in the last few years. You know, models have become all the rage now. You know, they are the rulers of the gods and really dictate everything else we do. So we can develop mathematical models of individual drugs, of their pharmacokinetic behavior within a population, and that could be an ICU population, that could be an ambulatory population on a ward in a particular disease or specialty. And by developing a model, by feeding all that information in, you gather the data, and we can do that quite easily these days because of electronic health records. We can develop the models, and we can use those models to then individualize that patient's pharmacokinetics, and then you can individualize their dose, truly individualize, and then hit that target that you want to hit. So then that comes on to the other slide that Kevin presented, which is your AUC-MIC ratio, your Cmax-MIC ratio. Once you've decided that's the ratio I want for this patient, this is the dose, because this is their pharmacokinetic characteristics to get to that. Okay, so that's what precision dosing is all about. And that might seem really far-fetched, but actually it's been implemented in hospitals around the world, not much in the NHS. We did do a study on vascular surgical ward doing that very thing, which is to we use the Vancomycin population model, we use patient's level to feed back into the model, and then individualize their pharmacokinetic characteristics, individualize their dose. Okay, so I think, you know, if we're talking about the future is bedside rapid monitoring, and one of the things Piyush really highlighted is the delay we have in the system of getting levels back. In the future, it should be possible, and I don't know when that is. I say future, you know, in the NHS it could be another 10, 15 years, but it's doable now. It's not beyond us. you know, I know a couple of companies that can do bedside monitoring of vancomycin. It's just that, you know, we don't have the means and the resources in the NHS to implement that, but it can be done. Okay, so you would almost like a glucose monitor. I've seen the device that they've developed. It's like a glucose monitor. Okay, it could be done with your array of other blood gases and using and that sort of thing that you do on the unit, and you get your vancomycin level, or you get your tazocin level, or meropenem level, whatever. Okay, it reads out. You plug it into a decision support tool. So that's the model, which is be on your desktop computer, and it will tell you what that patient's PK characteristics, individualized, personalized, and what their dose should be. So that is really where antimicrobial therapy is headed. But it's not just antimicrobial therapy. We can apply that to various other scenarios, but be it in anesthetics or cardiology or wherever, oncology, particularly useful in oncology. And then just one or two other things to pick up on that was highlighted through Piyush's cases was, one of the problems at the moment is obviously you don't know exactly when to take a level, or you might know, but the level was taken at the wrong time. What do you do with that level? Well, with this approach, with a decision support tool model-based approach, it really doesn't matter when you take a level. So that level that Piyush said discard and just carry on, you actually would use that level. That's a really perfectly good level to then feed into the model to then individualize your dose. So that would be a huge benefit. Yeah, I mean, some of the covariates that Piyush was picking up on, the renal function, the age, okay, and then voriconazole pharmacogenomics. That's the other thing. So voriconazole is very much dictated by your genotype for a particular enzyme. Piyush was quite right. You don't alter dose and renal function. The main reason is because it's hepatic metabolized. You don't really need to worry about renal function. But hepatic metabolism is polymorphic in the population because of different genotypes affecting that particular enzyme. And we can do bedside monitoring of genotypes for various enzymes. And again, that will help you individualize the PK and therefore individualize the dose. And again, that's not far-fetched because I'm actually doing it at the moment with a study that I'm running with Voriconazole, looking at genotype-based dosing. So, it's in research at the moment. It might be 5-10 years down the line before you guys are using it. But that's where I think we're going with pharmacogenomics as well. So pharmacogenomics are the best bedside PK model-based decision support tools and rapid, instant bedside monitoring of antibiotic levels that you feed into the models that give you the right dose that hits the target, so you're not guessing all the time. TDM is fine. It's slow. It's reactive. Model-based dosing is proactive, and that's the difference. Is that okay?
Perfect. Thank you for saying that. That's absolutely brilliant. I think that's pretty much the end of the presentation now. I'm not sure where the presentation has actually gone, but I don't think it matters too much. So I think, do we hand over for some questions now, Zoe? That normally works?
Yeah, pretty much. Thank you very much for that.
That's all right.
That was very in-depth. Questions? Dr. Briggs put a question on the chat. Hang on a second. She says, do you think survival is the right primary outcome measure for the studies? I think she was talking about the ones that you mentioned about the antimicrobial infusions. Did they look at, she says, did they look at clearance of infection as well? Was there a difference in that?
There was actually a difference in clearance of infection in the Bling 2 study. I don't think there was in the Bliss study, from what I remember. So yeah, there was a difference in clearance of infection, but it didn't affect ICU length of stay either. So no mortality, no mobility, and so from what I understand, not many places still have changed their practice because the evidence isn't strong enough to make a wholesale change across the board, and particularly for continuous infusions. And the evidence is a bit stronger for extended infusions because the negatives of those are reduced. So you're not tying up a line for 24 hours, and it doesn't affect your access. So giving Tazocin and meropenem over 3 to 4 hours, rather than giving over 24 hours, and you don't have to worry too much about the stability of those drugs as well when you're running them for over reduced time periods. I think that may become more standard practice, extended infusions. I think for continuous infusions, I think the evidence still needs to be greater to make a wholesale change.
It would be quite annoying if we had to, because everybody's on Tazocin or meropenem pretty much. If we tied up a line for the entire time of their stay, that would be quite irritating.
Yeah, exactly. Yeah. But particularly at the Royal, I think when access for some of the patients there can be challenging as it is already, that certainly add another layer to that.
Yeah. She says, was there any reduction in the duration of the course of antibiotics with the infusions or not?
I'm not sure that was measured. From what I remember, I'm not sure it was measured, but I don't recall that being in the studies that I looked at.
We've been talking about doing continuous infusions for ages, haven't we? But
yeah, so I mean, I don't know if Hussein thinks there's any more insight into continuous infusions, whether you think they're.
Well, I'm not familiar with that. So I'm not familiar with the ins and outs of that study. I was wondering whether they collected any PK data, so you can actually see whether the difference in exposure between those two.
Yeah, I think the PK data was actually promising on the studies it seemed to imply that the theory was correct in terms of.
You were maintaining.
Yes.
Time over MRC.
Correct.
For longer the continuous.
Yes.
Was there a difference in safety? So you're saying there's no difference in efficacy, perhaps question mark of mortality, but what about safety? Less side effects, adverse effects,
non-inferior to bolus administration. I think there wasn't enough of a difference either way, from what the studies showed.
Okay.
So nothing significant difference in terms of safety. Yeah. Would you think it'd be more safe or less safe?
It's difficult to say. I mean, with intermittent dosing, you've got high peaks. The profile comes back down, high peaks go. So there may be some off-target effects. When you get a high peak of a drug circulating, you might get off-target adverse effects. You're less likely to get those with a more continuous infusion. But a continuous infusion, you're going to have a different PK profile within tissues as well, and whether that could result in more adverse effects. You might have more distribution into certain tissues.
I hope the larger study will give us more information from next year. 7,000 patients is a big number for any critical care study. So
that's a huge.
It's a huge study.
Very heterogeneous population, and that whether there's only 7 analyses to show whether there are.
Yeah, I mean that may well end up changing some of our practice when that gets reported, with being such a large study, or maybe may change practice of the units have already switched over. Anything else, Zoe?
No, I don't think so.
Anyone in the room here? Anyone in the room at the Royal? Natasha, is anyone there? Got a question?
No. Bamboozled everybody. Thanks very much, guys.
All right.
Cool.